Welcome to this EURO-NMD webinar that is organized with the ERN for Rare Neurological Disorders and the European Academy of Neurology. This is part of myopatology group of webinars. And we have today Werner Stenzel, that is regular in our webinars, fortunately. Thank you, Werner, for accepting. And he's going to talk about the role of muscle biopsy in inflammatory myopathies. For the very few of you who do not know Werner Stenzel, I'm going to introduce him. He's a neuropathologist and myopathologist, and currently the head of the neuromuscular diagnostic and research unit at Charité Hospital in Berlin. He acts as co-director of the German Reference Center for Neuromuscular Diseases, and he has a primary research interest in inflammatory muscle and nerve, peripheral nerve pathologies. His lab is famous for those two research topics, and he has received over time many researchers and clinicians in his lab for developing their skills and collaborating in the research work that is ongoing. He's got an interest also in ultrastructure myopathology, and is lucky enough to have it as a support for diagnostic, not only research, but also diagnostic routine. And is currently having duties as Associate Director of the Journal Neuromuscular Disorders and Executive Editor for Neuropathology and Applied Neuropathology, another publication. He's got roles, namely for the research working group in our European Reference Network, EURO-NMD. And I remember very well the Congress in Berlin 10 years ago, by God, time flies, that you've organized with Hans-Hilmar Goebel and Arpad von Meurs. So welcome, Werner, and once again, thank you very much for your contribution.
Thank you, Antonio. That's a very kind introduction. Hello, everybody. I'm very happy to give this talk today. And I must say that I have also very normal duties, and have to leave at 4:45 because I have to give a seminar at 5 at another campus. So today's lecture will be a little bit briefer than the usual ones. This also relates to what I'm showing here. So I was asked to talk about the inflammatory myopathies, and today I will only talk about dermatomyositis, immune-mediated necrotizing myopathy, and anti-synthetase syndrome, and a very little bit about IBM. But as you can see here, there are many others which have, for example, been called overlap syndromes like scleromyositis and myositis that is associated with anti-KU antibodies or UNRNP antibodies. So those are mostly seen by rheumatologists in certain contexts, like, for example, scleroderma or Sjögren syndrome, etc. So there's a huge group of myositis that does not primarily fall into those four here, and some of those have actually been called polymyositis in the past. Now we know them much better, and we know the clinical morphological spectrum much better. And I will also not talk about eosinophilic fasciitis. There's immune checkpoint inhibitor-induced myositis, very important topic, and sarcoidosis, viral myositis, etc. So there could be another date where we could meet and I could talk about this in the future. Anyways, so the inflammatory myopathies of today's talk are the dermatomyositis, different subtypes of dermatomyositis actually. So it's a spectrum, and it's a huge spectrum of diseases, and they are all called today dermatomyositis. That may change in the future, but it's called a dermatomyositis spectrum. And I will tell you about what I think is the spectrum there also on a morphological point of view. There's also immune-mediated necrotizing myopathies. In the past, personally, I thought it was a much bigger spectrum, but now the paradigmatic two types of IMNM that we should consider the core types of IMNM are the SRP and the HMGCR associated types of myositis. And there are seronegative types, but they are really rare, I would say. It's not a third of 1/3 of cases. They are really rare. And all the others should not actually fall into this group, I think. And then there's anti-synthetase syndrome associated with a bunch of different autoantibodies. We'll come to this. And the IBM is also, I think, a spectrum, and I put a question mark here, because it has not been discussed so much under this consideration that it may be a spectrum. But I think that could be the topic of a whole lecture on its own. So as you see, I'm advertising myself. Sorry for that. But that could be an important and interesting topic as well. So two things I'd like to mention is one is the autoantibodies that now everybody knows very well, and a lot of our work in the past that we have done with many people that may be present here today as well, or that you all know, has been conducted with the aim to identify certain morphological features that correlate well or that characterize the myositis subtype. So, for example, the MDA5-associated dermatomyositis looks very different from the Mi-2-associated dermatomyositis. And that was a lot of work that was done in the past by us and others. So there's the dermatomyositis autoantibodies, and then there's these autoantibodies that may fall into the group overlap myositis. There's this antibody that is mostly considered now as a myositis-associated antibody, or associated with especially IBM, but it can occur in other contexts as well. And those two I've mentioned already. And you see here this cancer area. So this is something that is, of course, important, like a multi-organ involvement. It's not only myositis, it's also about the lung, it's about the skin, the joints, and of course also cancer can occur in this context. And then there's another thing that is important, or that has emerged as an important issue, is the so-called interferon signatures. And there is a type 1 and a type 2 interferon signature. There are other interferons, of course, but those two are really important. And it has turned out that dermatomyositis is really characterized, irrespective of the autoantibody we are facing, by a so-called type 1 interferon signature. And this has been identified by many different groups in children and in adults. And there are very interesting boundaries towards hereditary interferonopathies in childhood. And as you can see, those genes that pop up here as being really, really very red, they don't pop up in the other types of myositis. So this is something that can be used as a form of biomarker. So let's dive into the dermatomyositis spectrum, the largest spectrum, I would say. There's a huge clinical variability and huge morphological variations in dermatomyositis. There are these 5 autoantibodies, and I must say the last one here, SAA, is really, really rare. This is characterized, as I said previously, by this so-called type 1 interferon signature in the serum and in the muscle as well. So that means that you can identify a number of very highly specific genes upregulated that are produced in these patients. So for us as morphologists, we don't look so much at the blood, we look at the muscle tissue, and we can identify this type 1 interferon signature by common stains that are now largely accepted and widely used, like MXA or ISG15. We can also do electron microscopy to identify interferon signature alterations. And you all know these famous so-called tubular reticular inclusions in the endothelial cells that can be found from capillaries, for example, that can be found by transmission electron microscopy. But those can also be identified, for example, in lymphocytes. And this is also feasible and doable for us. So how does the MDA5 type of dermatomyositis look like? And one interesting thing is that there is 30% of anti-MDA5 positive dermatomyositis patients have a very dramatic and very bad prognosis because they develop not a severe myositis, they develop a very severe lung problem. And this is, some call this the fatal or catastrophic lung disease. And this, what you see here is this, and you see those hyaline membranes. You can barely identify pulmonary tissue here. So those are the alveoles, and those are the hyaline membranes. And this is exactly what you see in severe COVID-19 lungs. So there is a very close resembling between those two stories here, the lungs in MDA5 and the lungs in COVID. You can also see those fibroid deposits in skin vessels, of course. So on the morphological level, it's often not very dramatic. One has to identify the perivascular atrophy in some of the fascicles. This is something that I always tell everybody. Of course, you don't see this perivascular atrophy in every fascicle, but in some of the fascicles, it should be visible. And it should be identifiable also by other stains and highlightable. Like, for example, with MHC class 1, but one can also use NCAM to highlight the perivascular pattern. It's MHC class 2 negative. There are some macrophages often in the perimysium and the epimysium, and there's not a specific pattern for complement in those cases. So clinically, they are often also very variable. Some of those patients have this inverse alterations on the hands, but that's not our topic today, but I just wanted to show it here. So those are pictures that I owe to Olivier Benveniste from Paris. But what you can see here is that this is the boundary towards the genetic diseases. So there are host wRNA strands or viral RNA strands, and they may induce a gain of function of certain molecules, and you see the MDA5 here. But there are also loss of function mutations, for example, by genetic diseases like Aicardi-Gouttières syndrome caused by TREX1 mutations, and that also translates into the upregulation of the so-called interferon signature. So this is very closely related. And why is this all important at all? So you can see here, and I mentioned it, around about 30% of those very severe, not all of them are very severe, but these 30% that have the catastrophic lung problem, they die. So they have a very bad survival curve. And if you use this this knowledge that there is this type 1 interferon signature, which is really important in this disease, one can block this with JAK-STAT inhibitors, like, for example, tofacitinib and others. And in this study, for example, here they identified, or they treated 18 patients with amyopathic dermatomyositis. Those are the MDA5 cases, and with this very severe interstitial lung disease, and they survived. So what's new in anti-MDA5? It's very frequent, or much more frequent in Asia than in Europe. Of course, one sees a lot of those cases in Paris as a center because there are many people from all over the world over there, but we see them relatively rarely here in Berlin. So as I said, there may be this dramatic lung involvement. 30% have this, but 70 don't. And it's rare to see this severe lung involvement in children. And there has been a very recent therapeutic approach, for example, but this is not the topic today, but I wanted to show it nevertheless. So this is some weeks ago. So people use this novel approach of T-cell engager therapy, and this lady here had an MDA5 dermatomyositis. So how does it look in MI2? So the MI2 cases are the textbook cases. So everything applies to those here, to the MI2, what is written in the textbook. So typical skin lesions, severe proximal tetraparesis, CK levels can be very high. relatively good response to treatment. But look at this, it can look very severe. So this is the typical picture we all know, perifascicular atrophy, meaning that in this perifascicular area, the fibers are atrophic, and towards the center of the fascicles, the fibers are more normal appearing. And as I said, this is very variable in the different fascicles. But there are areas that look like this. And this is the same biopsy here. So this can really look very bad and very dramatic. There's always this MHC class 1 positivity, and this is highlighting the perifascicular pattern, strong here and less strong towards the center of the fascicles in some of the fascicles. MHC class 2 can be a little bit positive, but this is really the only type of myositis where of dermatomyositis, where the MHC class 2 can be a little bit positive, and all the others are MHC class 2 negative. And complement is on the surface of the myofibers in Mi2 positive dermatomyositis. Sometimes one finds those typical perimysial accumulations of leukocytes, often surrounding certain vessels or larger arterioles, but not really producing a vasculitis type of picture with destruction of the vessel wall. This is what you see in adults, but there have been vasculitis types or vasculitis pictures described in children. So there's a certain difference between adults and children. So there's something that is really new. We all knew that the Mi2 autoantibody is targeting this NERD complex, and this is known since the mid-70s already. But what is really new and was not known in the past is that this antibody targets those functional subunits and upregulates a set of genes that is not identifiable in all the other types of dermatomyositis. So it's really a unique set of genes that is upregulated in this type of myositis. And this strengthens the concept that those are really different diseases. So they have a completely different genetic underlying genetic problems. So without going into too much details, this is work by Iago and Andy, and it's really worth reading it. TIF1 gamma dermatomyositis is a type of dermatomyositis that is easily recognizable. And why is it easily recognizable? Because it has this typical perifascicular atrophy, yes. And in trichrome, you see those violaceous fibers. Very frequently, you see those violaceous fibers. They look very special because they are not green, as we know from trichrome. And you have those so-called punched out vacuoles, punched out because they are not rimmed. And they are ill-defined. So this association of this seemingly already on the trichrome stain mitochondrial problem with the punched out vacuoles is really typical for TIF1 gamma. And the mitochondrial problem can also be highlighted by this combination stain many of us are using, COX combined with SDH, and you see that in this perifascicular area, obviously those fibers lack the COX stain, so they appear bluish. There's also something that is interesting and a bit mysterious. It's called the so-called ghost fibers, which you can only see at ATP 9.4, because they are fibers that are not stained at all, and therefore the name ghost fibers. So they are not dark and they are not brighter as all the other fibers at ATP 9.4. The inflammatory infiltrate is often relatively mild. CK levels can be very low as well, as you can see here. So those are some leukocytes and very little T cells in this case. But MHC class 1 is always very strong. There's something that is super important here, and that's the complement. The complement is identified on those capillaries here, and that's typical in TIF1 gamma. And also, that's something I mentioned in the beginning, MXA and ISG15 is strongly positive. So this is the type 1 interferon signature that you can use for all types of myositis, and it will identify the dermatomyositis subtypes. So what we all know since quite a while is that cancer in adult patients occurs in TIF1 gamma much more frequently than in all the other types of dermatomyositis. So that's really important, but there are some newer autoantibodies like SP4 and CCAR1, which are associated with TIF1 gamma, and those confer a lower risk of cancer, which is relatively recent and an important thing to do, because not all TIF1 gamma positive patients above the age of 40 have cancer. And frequently people ask me which type of cancers should we watch out if the patient don't have cancer. So often breast, ovarian, lung, nasopharyngeal, but in general no hematological cancers in TIF1 gamma. And something also really important for the pediatricians among us, or for those that have a lot of contact with pediatricians, TIF1 gamma is a typical antibody in children as well, but it does not confer any risk of cancer in children. So this is really something that accounts only for patients and only for adult patients above the age of 40. NXP2. NXP2 has a broad manifestation, and it's really important to remember from a clinical point of view, but also morphologically. So oftentimes NXP2 is edematous. So the so-called edematous type of myositis is often NXP2 positive. And that's an example of a child that I owe to Ulrike Scharer from Essen, colleague from pediatrics. Morphology-wise, it looks a little bit similar like the TIF1 gamma cases, but less prominent in terms of atrophy often, and a little bit more inflammatory, but this is something that one can only like occasionally see. MHC1 is positive in the perifascicular area, gets less positive towards the centers of the fascicles, and like in TIF1 gamma, you see complement on the capillaries, and not so much or predominantly on the capillaries, and much less on the surface of the muscle fibers. As I said, inflammation can be more prominent than in TIF1 gamma, is often more prominent than in TIF1 gamma. You see this COX-SDH pattern, which can also occur here. So that's nothing super specific for one or the other disease. But what's important is that in NXP2, you can have very high CK levels and area-wise necrosis. So that means that it's really not a necrotizing myopathy, meaning that single fibers are necrotic, but it's really an area-wise necrotic part of the muscle biopsy with so-called focal ischemia. So this focal ischemia is something that is really typical, but not exclusive, of course, for NXP2. Something also important, but this is also relating to the clinicians, often the rheumatologists. In NXP2, one can have dermatomyositis, sine dermatitis, meaning that there is no dermatitis. At least in the beginning, some of those develop pure dermatomyositis or classical dermatomyositis in due course. But that's something important, because according to the classification criteria, you cannot call it dermatomyositis without dermatitis. So that's the classification system. But this can occur in NXP2. There's also this topic of calcification, subcutaneous calcification, which occurs in children. Also an important issue that we can sometimes also see in our skin biopsies. Okay, we are switching gears to the necrotizing myopathies, and I just put this up here because we are only talking about this and this here, and all the others we don't touch. But this can, just to mention that a picture of necrotizing myopathy, of course, as you all know, can occur in other contexts. So it's super important to identify the cases that are disimmune and associated with those antibodies, and all the others that can really mimic. sometimes it's very difficult and hard to identify the true IMNMs from others. So how does a true IMNM look like? IMNM is characterized by single fibers that undergo necrosis. And as you all know, necrosis is not a unique feature. It's a spectrum again. So when a fiber decides to undergo necrosis, it first becomes pale, and then macrophages come in, then it develops a granular type of necrosis, then it disappears, and then regeneration takes place, of course. And all those different patterns you can see on the biopsy. And that's, I think, really important to identify different stages of necrosis and regeneration that are scattered all over the place, and no particular pattern in any of the areas, perifascicular or somewhere else. So that's the typical H&E and trichrome stains that you can identify. Oftentimes, inflammation or lymphocytic infiltrates are really rare. Sometimes there are exceptions, but in general, it's a rather mild inflammatory myopathy in terms of infiltrates. Can be very dramatic clinically, but the inflammatory infiltrates sometimes are really mild. MHC class 1 should be positive. And here I must admit that this is really one of the strongest reactions that we get. Sometimes it's much milder, and only single fibers are showing this sarcolemmal positivity of MHC class 1. And what's important, SRP and HMGCR is always MHC class 2 negative. There are no exceptions. Well, I know that one should never say there are no exceptions, but I say it because if you see a strong MHC class 2, one has to consider another type of necrotizing myopathy that is not the prototypic IMNM associated with SRP and HMGCR. Something that is important is the complement stain on the surface of the myofiber. So we often use C5b9, but here's C1. You can also use C1q to highlight that it's the classical complement pathway. What is also very useful is this pattern of P62 stain that we always use now. And it's a fine punctuate pattern of P62 that occurs in this context. And again, sometimes you can see a slightly similar pattern as well, but having seen a lot of those IMNM cases, one can train their eye towards identifying the true P62 pattern of IMNM. And the P62 pattern in IBM is very much different. It also has some punctate, but they are more coarse and more like bigger and often associated with vacuoles or perinuclear. So pathogenesis, just very briefly, there are two types of pathogenesis discussions going on. One is this here. We have the antibody. The antibody attacks the myofiber. Myofiber undergoes necrosis, and then regeneration takes place. And the antibody is expressed at the surface of those regenerating fibers. So this is well shown. This is also well shown in animal models. And then you have the young myofiber, and then a vicious circle takes place. And this also involves a lot of atrophy, of course. On the other hand, blocking complement has not been very effective in this disease. So there must be something else. And there is something else that leads to this punctate P62 pattern that I showed you. And that's the ER stress that occurs in IMNM, and this leads to a certain type of autophagy, which is called CASA, and this is also something that is really important in the pathogenesis of IMNM. You can highlight this, and we use this for diagnostic purposes, but we have not, of course, illuminated the whole pathogenesis of IMNM with this hypothesis. I just briefly mentioned this here because I don't want to run out of time. But what is important for the pathogenesis thoughts in IMNM is that there has been genetic alterations in the HMGCR gene, and this occurred in children, and it produces a similar picture in children. It is really comparable to the autoimmune type of myositis with HMGCR autoantibodies. And this has been described in here in 5 families by the group of Carsten Bönnemann and others, of course. And this is really something that is super interesting and super important, highlighting that this autoantibody targeting this molecule is really implicated into the disease, because you know, in the immune rheumatology and immunology world, there has been a long ongoing debate as to whether those antibodies are just bystanders or really pathophysiologically involved into the disease. And one could discuss about this much more longer, but this, I think, this is a nice proof here of this concept. Okay, let's switch to anti-synthetase, and again, it's a spectrum that that involves multi-organ problems. So of course we have the muscle, but we also have the lung, we have the skin. You see those mechanics hands, you see the Raynaud syndrome, and you have patients with arthritis. And all those symptoms here can occur at the same time, but oftentimes they occur one after the other. So that maybe you find one encounters patients that start with the lung or start with the joints and then later on develop the muscle problem. So this just highlights that there is really also a multidisciplinary problem, and therefore I think it's important to know about this multi-system involvement. Those are the autoantibodies that can occur, and most of them here are well known. The most well-known one is the anti-GO1, PL7 and PL12 are the other ones that are relatively frequent, and all the others are super rare. OJ antibodies, that's a complex, so it's not one antibody, it's a complex of autoantibodies, and then the ZO, for example, that's super rare and has only been described once or twice in the literature. So how does it look under the microscope? And again, here we have a necrotizing type of myositis, but here the necrotic fibers are in the perifascicular area. They are not diffusely scattered around all over the muscle fascicles. They are really confined to the perifascicular area. And as I said with dermatomyositis, of course, this is not the case in every fascicle, and it's not super nicely visible like you can see it here in all cases. But if you have a decent amount of muscle tissue to look at, in 1 or 2 of the fascicles, one will find this typical pattern. So a necrotizing perifascicular type of myositis. Oftentimes one will see alkaline phosphatase positivity. You see these perimysial area, which is edematous and fragmented. And this is shown, or this is highlighted, for example, by alkaline phosphatase, highlighting activated fibroblast that you can also see here. So on the ultrastructural level. And something else was really surprising to us when we looked at all of those cases. Many of them, not all of them, have nuclear actin accumulations. This was super surprising for us and still not super well understood. What's the actin doing here and why is it aggregating in this inflammatory disease? But that's something that you can use as a diagnostic tool. And we have not seen this in dermatomyositis, for example, which can sometimes resemble anti-synthetase. But how can you differentiate between dermatomyositis and anti-synthetase? It's actually quite easy, just by doing MHC class 1 and MHC class 2. So anti-synthetase is always MHC class 1 and MHC class 2 positive. There may be exceptions, but in most cases you will find this. And what's more is that the MHC class 2 in frequent occasions is even more stronger than the MHC class 1. And sometimes MHC class 1 is more ubiquitous and MHC class 2 highlights the perifascicular pathology here. So that's different from from the dermatomyositis cases, where occasionally you can have a little bit of MHC class 2 in the perivascular area, but it's not as strong at all as in anti-synthetase syndrome. And coming back to this picture that I showed in the beginning, here it is again. Here we have the dermatomyositis, and here we have the anti-synthetase, in this case GO1. And you see it's a little bit more red than looking at the HMG-CR or the SRP or the IBM or the normal controls. So one could say that it's a little bit similar, but less strong, and that's actually also the case. You know, you can look at hundreds of those type 1 interferon genes and also type 2 interferon genes, but the typical ones that are upregulated in dermatomyositis versus those in anti-synthetase are different, and that's highlighted in this nice paper, and it has been reproduced by others. So what we've seen also by looking at electron microscopic pictures, again, here are the fibroblasts, and there are some plasma cells as well here, as you can see here with those nicely shaped nuclei in the perimysium. So we think that those plasma cells that reside in the perimysium and that are activated, they are CD38 positive, for example, that they may be responsible for sustained autoantibody production in the tissue, which is different from the autoantibody production that occurs in other localizations of the body. So what is new here in anti-synthetase? We have B cells and plasma cells that reside in skeletal muscles in the perimysium. This can be called an immunological niche. You can stain those, of course, and identify them. In most cases, they don't occur in true secondary lymphoid organs, like in those really round structures that resemble a lymph node. They are more like diffusely scattered in the perimysium, and we think that this contributes to local autoantibody production. And this is likely the reason why these pioneers of CAR T-cell therapy have used anti-synthetase syndrome as their first myositis subtype to try this therapeutic approach, which was rather successful. So for the last couple of minutes, let's talk a little bit about IBM. As I said, I would be super happy to talk about IBM only once in a while, because there are really a lot of new things that have emerged and super interesting things that have come up. But how to identify IBM and how to differentiate IBM from vacuolar myopathies that may be IBM mimickers. It's actually sometimes not so easy. So we have, I think, 4 important domains. One is the inflammatory domain. One is this vacuolar degenerative domain. That's the mitochondrial pathology. And then the severe myopathic dystrophic picture. And what's important is to keep in mind as myology or myopathologists who don't oftentimes see the patients or who have little contact with the patients, is that we have to keep in mind that this is a chronic disease. All the others that I mentioned are acute or subacute. So this is a disease where biopsies come to us after 5 years in general of disease duration. So of course it produces a different picture. So we have a lot of fibrous tissue here in between in the endomysium. We have a lot of inflammation. I'm always telling the young colleagues here in the institute that that's actually the most severe inflammatory type of myositis. And it's really surprising that anti-inflammatory approaches don't work well in this disease. Sometimes you have necrotic fibers, of course, but you see the super important atrophy of fibers. And also you can see those small vacuoles here as well. Severe inflammation, and like in the 90s and early 2000s, a lot of people have really focused only on the T cell as an important cell in IBM. And there are a lot of interesting things that came out of those studies. IBM is always MHC class 1 and MHC class 2 positive, which is really super important. And that's one of the main messages for IBM diagnosis. If one is not sure about the diagnosis, if it's MHC class 2 negative, consider an alternative diagnosis. That's one of the messages I would like to deliver. Of course, we all know about the nice rimmed vacuoles that can occur, and sometimes one has a hard time to identify those vacuoles. And there are even papers out by Tom Lloyd and others who say, well, we don't need those vacuoles to identify an IBM. But as morphologists, I would say we are much more comfortable when we see those rimmed vacuoles and write a report saying that is really IBM. Just to highlight that the concept of clinicians that look at IBM and morphologists that look at IBM can be quite diverse. So how to identify the vacuoles, how to stain those vacuoles, how to stain what's wrong in those fibers. Many people have done a lot of different stains, and they are all really very useful, and some are more useful than others. And in some hands, this or that stain may be more useful than another stain. But one of the gold standards is the P62, and I think a lot of us agree about this. But other people use other stains, so I don't blame anybody for using another stain. Of course, you adopt your eye to the pathology that occurs in certain diseases if you use one stain all the time. And so this is the P62 pattern, I would call it, for IBM, typical one with coarse, larger regions that have this autophagic, highlights this autophagic problem that obviously occurs in this disease. Oftentimes you have this vacuole, and then there's something in the margins of the vacuoles, and sometimes you have this perinuclear P62 positivity as well. So that's one of the gold standards, and that has been studied in this very nice paper by Stephen Brady and Janice Holton from London. Well, Stephen is in Oxford now. So to finish, you all know that the tubulofilaments are super nice to see, and we all love to see electron microscopy, and that's how they look. But to be honest, or to be like realistic, a lot of people don't do EM anymore, and so this very important pattern of identification of those tubulofilaments, be it in the vacuole or in the myonucleus, has disappeared from the diagnostic criteria. Nevertheless, I encourage everybody to do this still, because of course it's not unique in IBM, so there are other diseases where you can find those tubulofilaments, of course. But in the whole spectrum, if you have the whole spectrum together, of course, one again feels much more comfortable to call something by a certain name. Also, what's super important, at least for us, is to identify mitochondrial abnormalities in IBM. And here you see nice paracrystalline inclusions and COX-negative SDH positive muscle fibers. Sometimes you see ragged brown, ragged blue fibers, ragged red fibers as well. And of course, as I said, the EM things. And as I mentioned in the beginning, it's in most cases, it's already quite advanced. So you have really like a dystrophic picture in many cases. And in much advanced cases, like let's say after 10, 15 years, there's also a lot of fatty replacement. Okay, what are the take-home messages? So the muscle biopsy is really key. Of course, I don't have to tell this to this audience in the diagnosis of myositis. Autoantibody testing is really important and should be combined to the muscle biopsies and to the muscle biopsy results. And we report both together to have a clinical pathological and autoantibody profile-based myositis classification. So one example could be TIF1 gamma positive dermatomyositis cancer associated, and formally one would also only call this DM, or anti-PL7 anti-synthetase syndrome associated myositis, and formally one would call this PM or DM or whatever, and the same is true for those others here. So with that, I'd like to finish, and yeah, thank you, and I'm happy to take 2 or 3 quick questions because I really have to rush.
Thank you, Werner. The first in line is Christian Saris. He's got a question for you. Can you unmute yourself, Christian?
Yes, no problem. Thank you, Werner, for your beautiful presentation. And as you mentioned, very short question to add on your presentation. I was wondering, do you know the difference between the MXA and MX1 staining? So they're different antibodies. I'm not sure if you have experience with both stainings. Can you elaborate a little short on this?
Yes, I know that a lot of people struggle, including us, struggle with the new antibodies. So in the beginning, there was an antibody that was provided by Santa Cruz, and then a lot of other companies have joined in and produce antibodies, and they are much less like useful. We use the one that is from Millipore. I can say it here. I don't want to advertise the company, but this one works in our hands, and it's one of the MXA antibodies that works.
Excellent. There are no questions in queue, and you're a bit pressed by time. So if no one rapidly shows the intention to put a question, I would end this here. I thank you.
Write me an email otherwise.
Yes, and with that extra possibility. Your email is on our website, so anyone can go and see it. So thank you very much, Werner, and this was very useful, and I'm sure that you'll get a couple of emails afterwards. See you next week or very soon at least. Thank you.
Bye-bye.